Hope the audiences have benefited to some extent, and it will definitely improve nutrition care practice. We will take questions from the audiences in question answer session. And to move on, I would like to invite our next speaker, Daphnee Lovesley. Daphnee is a chief dietitian and head Department of Dietetics, Apollo Hospitals, Chennai. She holds professional diploma in clinical research, and currently she is a PhD scholar who has done works in analysis of nutritional deficits in Indian adult patients with end-stage liver disease and influence of nutritional support on peri and post-liver transplant outcomes. She has 24 years of clinical experience at Apollo Hospitals. She also runs clinical nutrition courses and is a course director for Apollo Clinical Nutrition and Dietetics Internship Program. And she is also a member of IAPEN. I would like to invite Daphnee to continue with her talk. Please, ma'am, over to you.
Thank you, Dr. Hem. Hope I'm audible. You're able to see my screen?
Yeah, ma'am. Slides are visible and it's clearly audible as well.
Thank you. It's indeed my pleasure to join you all in this international webinar. I'm really happy to be part of this program because I see a interprofessional link in this. We do talk about multidisciplinary teams. Yes, in practice, Dr. Dabhi did speak about nutrition support team in hospitals, but in this webinar, I did see nurses, doctors, and dietitians coming together, which is really lovely. And I'm really glad to be part of this webinar. I thank the organizing team, Dr. Hem, Nani, and others for the invite. So without much delay, let's move on to the topic, total parental nutrition, basics and beyond. So this is a very interesting topic. I'm going to start with the basics and move forward so that all of you get benefited. So the outline goes like this. I will start with the evolution of parental nutrition, types of nutrition support, terminologies, indications, components, what are the different components that go into parental nutrition. And I'll touch upon micronutrients, guidelines, importance of timing. By and large, Radha did touch upon that, but in specific to PN, I will be touching upon, and steps in ordering TPN. Very simple few steps. And what is the delivery method? How do we deliver? And why is it important for us to monitor? And finally, the complications of PN. So when we talk about evolution of TPN, 1940s itself, it was planned. And in 1960, a full-fledged complete PN was first introduced by Dr. Ritland. That was basically with soybean emulsion, and there was a lot of new progressions happening in the past. Nearly it's 60 to 80 years now. So, but still, as Indians and maybe Nepal part of the world, we are a little more primitive compared to our global partners, right? Because the availability is also very, very few. Only few companies we do have which give us the products, right? So we will be looking at the different aspects of TPN now. So as far as evolution goes, there is a lot of changes that has happened. It started with soy and it has come to a fourth generation lipid emulsions which are available. And in 80s, we called it artificial nutrition. TPN, whenever we spoke of, it was hyperalimentation because, we didn't have much of clarity those days. We used to feed the patient 40 to 50 cals per kg, and it used to be in different bottles. It was not in one bag as such. It used to be in separate dextrose, amino acids, lipids. Each component has to be put together in order to meet the requirement. And a lot of complications were Previously, it could be line infection, acidosis, or hyperglycemia that could be attributed to the increased energy that was provided, as well as I told you, early phase, it was more soy-based lipids, which could be one of the reasons for the infection. And since before you start about TPN, let's understand the base of a critical care illness. Malnutrition goes hand in hand with critical illness. All of us know about it. When we talk about classic malnutrition, it takes months to years. But when we talk about critical illness, the patient is in a stress state and it takes only few days to weeks for them to go into malnourished status. Though a patient on admission might be well nourished, in a week's time, when you go back and see the patient, he might be in a different setup altogether. That could be attributed to the infection that patient has, which can lead to catabolic state, leading to negative nitrogen balance, leading to malnutrition, which in turn leads to impaired cellular and humoral immunity. There is impaired immunity leading again to infection. So it is a vicious cycle which goes on and on and on, which is very, very common in critical illness. So what are the goals for nutrition support? Why do we talk about nutrition support? Why is it important? Because we need to support immune function, we need to support organ structure and function, and to improve the wound healing. And all these are very important to reduce morbidity and mortality. So the final goal is reducing mortality and morbidity. So how do I start? How do I begin? Special nutrition support, it's a big question, right? So how do I balance it? Should I start enteral or parenteral? Whenever you have a question, you need to weigh what benefits you get out of the particular support. And you should outweigh the risk. What are the risks and the benefits have to be weighed, and the benefit should outweigh the risk. That's what we look at. This is being a logical thought process, and with this only people have put up all the algorithms, what Radha had explained. So when you weigh the benefits of enteral and parenteral, I'm not here to debate about it, but when we talk about enteral, it's a bit less costly, more complete nutrition profile compared to parenteral, and fewer complications compared to parenteral. When we talk about parenteral nutrition, easier administration, better patient acceptance, because there's no tube in the nose, it doesn't irritate them, right? Maybe patient perspective. Obviously, the absorption of parenteral liquids are any day higher compared to enteral feeds. But if your gut is working, use it. This is the mantra that all of us should follow. First comes food first. Next comes your ONS. Then comes your tube feeding. And finally, your parenteral nutrition. When we talk about a critically ill patient, the first option is enteral tube feeding. If your gut is functioning, please feed the patient, because that helps to maintain the gut, and it helps to avoid bacterial translocation. So let's move on to understand what parenteral nutrition is all about. Parenteral nutrition is nothing but a process of supplying nutrients via intravenous route. So total parenteral nutrition, it means all the components put together, you are meeting the total requirement of the patient. Peripheral parenteral nutrition, it is little difficult to meet the total requirement of the patient, but partially you will be able to support. Maybe it could be a supplemental parenteral nutrition, or in the initial phase, if in case you are initiating and then starting on some enteral, peripheral comes in very handy. It is often used in hospital settings, long-term care, and infrequently in home care setting. But I do differ in this. That's because globally you do have at least some percentage of patients surviving in TPN at home. under me across India, I do have about 10 patients who are on home parental nutrition supported only by TPN. So it is for survival. So that's why I became pretty passionate about doing more in parental nutrition. So these are some of the terminologies what we normally use: TPN, total parental nutrition; PPN, peripheral parental nutrition; IVN, intravenous nutrition; IVH, intravenous hyperalimentation, as I told you before. So what are the indications of TPN administration? It is prolonged ileus of more than 5 days. It could be due to mechanical obstruction or peritoneal carcinosis, and short bowel syndrome, which is one of the common indication for long-term TPN. It could be due to mesenteric infarction or extensive small bowel resection of less than 1 meter. And you do find these patients survive only with TPN, and it is a long process wherein they get rehabilitated, and some of them move on to having oral diets also. We do have patients in such a setting also. So it is really good to support them in using TPN for few months, stabilize them, rehabilitate them, and move on to oral diet. And severe malabsorption. This is also one common indication where TPN is indicated: excessive time to EN or oral. If a patient is not able to meet the goals within the first week of a critical illness through oral or EN, then parenteral nutrition comes in handy. And recurrent regurgitation, insufficient energy intake. It could be due to hyperemesis, critical illness, or poorly absorbed specific nutrients which can be supplemented. So let's move on to understand what are the components of parenteral nutrition, namely the amino acids, lipids, micronutrients. So before we go on to that, let's understand the difference between enteral and parenteral feeding solutions, because this was a bit discussed by Radha. I'm just touching upon the key points. When we talk about carbohydrates, in enteral it is maltodextrin, in parenteral it's glucose and protein. It's a fully balanced polymeric protein which includes 8% of glutamine. When we talk about parenteral, it's plain amino acids. It can be a different, incomplete blend also. That's because it does not have glutamine as part of it. If required, it has to be added on top. And lipids, it's a mixture of fatty acids, N6, N9 or N3 combination. Here too in parenteral, we do have a combination of lipids which can be used. When we talk about micronutrients, they are part of enteral feeding as discussed by Dr. Radha. If we are able to achieve about 1,500 calories, by and large, the daily requirement of the patient is met using that. But when we talk about parenteral nutrition, you need to add the micronutrients on top, because none of the parenteral nutrition solutions have micronutrients. So next, moving on to understand about lipids. Lipid evolution is a big process, and there are about 4 generation lipids available. Initially in 1944, soy, olive oil and lecithin solution was used for a severely malnourished child. In 61, 100% soy emulsion was used. It was a first industrially available PN lipid. 84, MCT LCT, that is soy and coconut oil combination. That was the second generation lipid which was available. 90s, you have the 80% olive and 20% soy. That was the third generation lipid emulsion. And 98, we did get the fish oils supplement separately as an exclusive omega-3 fat. And in 2000, you got a structured combination of MCT, LCT. And in 2005, we did get the 4th generation lipids. That's fish oil containing mixed formulas. So this is how the combination goes. It started with soy. Now it is composite oil emulsion with soybean, coconut, olive, and fish. You do get other olive oil based, soy and olive based emulsions also. So what are the advantages of having a lipid as part of parenteral nutrition? That's because it is a concentrated source of energy, and it reduces the need for infusing large doses of glucose. It prevents essential fatty acid deficiency. It is so important that we give, at least a minimal amount of lipids as part of parenteral nutrition, if in case you don't want the patient to go into essential fatty acid deficiency. And you do find essential fatty acid deficiency if a patient is deprived of fats for about 7 to 10 days. And you can, see a change in the Hallman index of more than 0.2 after 10 days. So lipids also help to minimize respiratory and metabolic stress. It decreases the osmolarity. That is very, very important when we talk about peripheral parenteral nutrition. And some fatty acids exert multiple and other metabolic immune effects also. Say, for example, omega-3 fats are, it's anti-inflammatory. So when we talk about LCT-based fats and its side effects, it can have altered pulmonary hemodynamics and oxygenation, which really could be attributed to the increased oxidative stress due to increased LCT, and it can lead to hepatobiliary disorders like the parenteral nutrition induced liver diseases like steatosis, cholestasis, gallbladder sludge or stones, which are common in long-term PN. And fat overload syndrome in infants if they are fed more than 3 grams per kg body weight per day. And overload of fat, especially LCT, can lead to hypertriglyceridemia and pancreatitis. And administration of IV fats can cause resistance to anticoagulation, especially in patients with warfarin. So it has to be taken into account because it can increase the production of anticoagulants. And LCT can also increase the risk of infection, which is very, very common. The first thing people fear is infection when we talk about parenteral nutrition. And microbial growth in IV fats are also, increased due to increased LCTs. So let's move on to understand about micronutrients, trace elements, and vitamins. All of us know about RDA of healthy people, but are we clear about the requirement of critically ill patients? How do we determine that? That can be determined by blood determinations, or you look at their, blood parameters. You can get help from tracer studies or balance studies, which can support. And when we talk about the micronutrient status, which gets threatened in critical illness, why does that happen? It could be because of the pre-disease deficiency. This was also discussed by Dr. Radha. So you need to understand about pre-disease deficiency and oxidative stress the patient is undergoing due to critical illness, which can increase the requirement of the patient. That is one of the reasons why you need to ensure that micronutrients are added, as well as I told you, in PN, micronutrients are devoid in the solution, so it has to be added on top. And it could be due to inflammation and lower intakes, less than 1,500 calorie, you may not be able to meet the total requirement of micronutrients in critically ill. And it could be attributed to the losses, conditions like, drains, urines, digestive losses, or treatments like, continuous renal replacement therapy, which can lead to micronutrient deficiencies. So should we use parenteral micronutrients and antioxidants in critically ill patients? What does guidelines tell us? The ICU guidelines by IAPEN 2018 tells us that Micronutrients, especially trace elements and vitamins, should be provided daily with PN. So every day your prescription should be there. It is in 100% agreement. It's a strong consensus statement. So every day you should be including a multivitamin and a trace element along with your parenteral nutrition, what you're providing. Why should that be given? That could be because of the deficiency, and it is generally that patients who come into critical illness generally have a suboptimal intake, and sometimes they are deficient also. In order to replenish and bring the levels to a normal range, a micronutrient supplementation is important. And when we talk about complement, it is in order to add on to the normal base level. And if we talk about supplementing, it is to super increase the normal value. So when does it become toxic? Especially when patients have multi-organ dysfunctions. It could be renal or liver impairments. That's why monitoring is very, very important. So what does guideline tell us about parenteral nutrition? When to start, what to start? As discussed in the previous, by my previous speaker, here too, when to use parenteral nutrition, IAPEN and NSCCM guidelines say that exclusive parenteral nutrition for low nutrition risk patients, those with a score of NRS score of less than 3 or a Nutric score of less than 5, you can wait up to 7 days because they are well nourished. So only beyond that, exclusive parenteral nutrition is required. When we talk about a high risk patient, a score of more than 5, it can, or a severely malnourished patient, when EN is not feasible, they suggest to initiate PN at the earliest, as soon as possible. And what is the optimal time to start a supplemental parenteral nutrition? Whenever you are not able to meet the goals of up to 60% through tube feeding in the first 1 week or 7 to 10 days, beyond that, you think of adding parenteral nutrition as a support therapy in order to meet the requirement. And once you are able to increase your enteral feeding to meet the targets, gradually the parenteral nutrition supplementation can be brought down. So what is the importance in the timing that we feed them? Why are we talking about 7 days, 10 days, as early as possible? That's because if you're going to start full parenteral nutrition in the early phase of critical illness, then what happens is in the acute phase, you start feeding the patient and there is endogenous energy production that happens in the acute phase of critical illness. So body produces about 50 to 75% of the energy that is required. On top of it, if in case you're going to feed them very early with a full feeding, then the total energy expenditure becomes quite high in the early phase. So the combination of endogenous and exogenous energy administration leads to overfeeding. That is one of the main reasons they comment on hypocaloric feeding in the initial 48 hours and later by 3rd day reach a goal of 80% and proceed further to 100% by the end of the week. So it is so important that you do not overfeed in any form of nutrition support in the early first 48 hours. It's not that you should not be feeding, you should not be reaching the target in the first 48 hours is the point to be noted. That is to avoid overfeeding, as we all know that overfeeding can be detrimental in the course of critical illness. So what are the other points what guidelines tell us? In appropriate candidates for PN Should the dose be adjusted in the first week? As we discussed now, we suggest hypocaloric PN dosing. I did explain why we should do that. So, or about 80% of the estimated energy with adequate protein. Please get it underlined. Adequate protein is mandatory. Only your calorie can be little less. Protein perspective, 1.2 grams per kg body weight can be initiated in the first week of hospitalization in the ICU for patients who are at risk or who are severely malnourished. Let's move on to understand the ordering of TPN. So what do we do? As a dietitian, what should I do when I'm called for a patient who is initiated on TPN? First thing is, I would be very clear to understand the nutritional status of the patient. So I need to do a nutrition assessment. Next, I need to understand the venous access evaluation. I may not be evaluating it. At least I need to understand which is the route of feeding, whether it is central or peripheral. Then baseline weight and baseline lab investigations are very, very important for a dietitian to note. So when we talk about nutritional assessment, I know Dr. Radha Reddy took us really in depth. So simple tool that we use in our practice is subjective global assessment. We do not do Nutrix score for all patients. Only those at risk we might extend to do a Nutrix score. That's because it's pretty laborious. And as a dietitian, this is a very simple, handy tool which can be used because it looks at the history of the patient for the past 6 months, looking at the weight change, dietary intake change, GI symptoms, their functional capacity, and their physical examination is looked at before we come to a conclusion whether they are at risk of malnutrition or they are well nourished. Why we look at the nutritional status? Because that also has a role to play in the poor outcome. Weight loss of more than 10% in 6 months, low serum albumin, energy, abnormal muscle function, high prognostic nutrition index, and an abnormal or a severely malnourished score with subjective global assessment can help you predict a poor outcome in the long run. So once we understand the status, next we understand the access. So when we talk about central vein catheterization, it is jugular vein or subclavian or the peripherally inserted central catheter. So these 3 routes we can use a central line product, or otherwise a peripheral line can be utilized. And when we talk about central catheterization, it requires a aseptic condition wherein all the intensivist put in the line. Only after that we come to play, right? We get to understand the status of the patient and we get to know which route we need to give the TPN. So when we go into the patient area, we look at the labs. It is so important that you understand the blood count, basic metabolic panel, calcium, magnesium, phosphorus, coagulation screen, lipid panel, and other tests if indicated. So let's start the step. First one, determine the total fluid volume. How much is allotted to you? So how much to give? Cater for maintenance and ongoing losses. These are very important, and generally the maintenance requirement is about 30 to 50 mL per kg per day. And the ongoing losses based on the IO chart. Consider insensible fluid losses also. It is adding 10% to every degree increase in temperature. These are components that you look at in order to finalize the volume that you give for your patient. Next comes determining the calorie. How do I do it? Based on total energy expenditure. It can be based on the predictive equations that are available, which is the resting energy expenditure with your stress factor and the activity factor. Or if you have a metabolic cart to do an indirect calorimetry, that is the gold standard. But in India and Nepal, I know many of us do not have it. We don't have the luxury to have it, so it is very difficult. Or finally, the thumb rule of 25 to 30 cals per kg per day. And if in case the patient is obese, use ideal body weight. If a patient is malnourished, especially severely malnourished, use actual body weight. It is very, very important for you to understand this. And the other ways of looking at it, especially in critically ill and obese patients, if you go by BMI, if the BMI is less than 15, you can have your target set as 35 to 40. That's your targeted goal. Whenever a patient is severely malnourished, start slow, gradually reach the target. And 15 to 19, 30 to 35, 20 to 29, 20 to 25 cals, and more than 30, it is about 15 to 20. And it is especially in critically ill patients. If they are non-critically ill patients, you can add on 20% to these goals that are given. And when we talk about ASPEN guidelines, for obese people, 30 to 50 BMI, it's about 11 to 14 kilocalories per actual body weight. And beyond 50, it is about 25 to 22 to 25 ideal body weight. So any of these can be used. And even in, ASPEN also gives similar target of 20 to 25 in obese patients. And they do advise in indirect calorimetry if it is feasible. And protein perspective, as we discussed, it's about 1.2 to 2. Next is the protein requirement. It's fat and carbs. Fat perspective, it is 25 to 30% of the calories. And they don't advise you to increase on soy-based IV fat emulsions of about 100 grams per week in the first week. If you could
Hello, everyone. Sorry for the interruptions. I think internet or web service at Daphne's place had some issues. So thank you for listening patiently and being with us. As soon as that, yeah. So let's continue with the talk.
Hello? You're able to hear Dr. Hem?
Yeah, now audible, ma'am.
Okay. Okay, when we talk about the electrolytes, so these are the common electrolyte requirements that we need to have in mind. Sodium 1 to 2 millimoles per kg, potassium 0.5 to 1, magnesium 0.35 to 0.45, calcium 0.2 to 0.3, and phosphate, it's about 20 to 30 millimoles per day. And trace elements perspective, zinc, it's 2 to 4, chromium 10 to 15, and copper 0.3 to 0.5, magnesium, it is 0.4 to 0.8. So next, let's move on to understand the additives. So I did discuss about the micronutrients. Vitamins give about 2 to 3 times the recommendation when it comes to an oral diet. So usually 1 ampule of multivitamin per bag is advised. And we should understand multivitamin does not include vitamin K. So we can give about 1 milligram per day or about 5 to 10 milligram per week. So now that we know how to give, let's understand the various options available in delivery process. So multiple bottle system. This was an age-old process. When I started my career in Apollo, that's about 25 years back, we used to give separate entities, glucose separately, amino acids separately, and lipids separately. It was not very easy, not at all easy, very inconvenient, and a high risk of contamination. Wastage of fluids is very common, and overall cost is also high. And what is safe? We need to understand that safe concentration of infusions, especially when we talk about central and peripheral line. Dextrose perspective, in central line, 25%, 50% is fine. Peripherally, up to 10% is okay. Amino acid, 10% and 5%. Lipids, in both, you can give 10 and 20% because that's low in osmolarity. And compounding methods, 2-in-1 bags are available, dextrose and amino acids, typically in a 1 liter bag, and lipids can be added intermittently. And that gives us a hold as to how much of lipid, according to the requirement, we can tweak it. Next comes all-in-one bag, total nutrient admixture, TNA, or all-in-one bags, which has the dextrose, amino acids, and lipids all mixed in one container. So the basic preparation has each component separate, 2-chamber bags, which are a little more convenient in order to tweak the lipids, 3-chambered bag, which is all-in-one, just mix it together, hang it, and control the volume what you want to give. And industrial mixtures are also available, but in India and Nepal, I don't think it is available as such, because we don't have separate units to prepare it. And PN, when we talk about PN delivery system, we have moved from multiple bottle system to all-in-one bags, which looks this way. And next, understanding about the multi-chamber. How does it look and how do we use it? So it's commercially manufactured, so it's easy to use, ready to use formulation in multiple chamber bags. So the container, the inner cover has the lipid, amino acid, and glucose. The outer wrapper, which is oxygen protected, it is tightly packed. And you do have the ports, injection port, and the center is the seal, which has to be broken when they mix it. And there is a infusion port also. And good manufacturing practices are followed. Compounding process is qualified and validated. Labeling according to defined standards, quality and process control, and there are a lot of inspections that happen, and it is properly stored and administered. There are instructions given which has to be maintained. And this is how it is mixed. To mix a 3-chambered bag, the preparation has to be done in a aseptic place, wherein the bag cover is opened. First, carbohydrate and amino acids are mixed, and then the lipids are mixed together. Initially, the colorless liquids are mixed, and then the white milky lipid is mixed. Then it becomes a milky white preparation, which is hung in the stand. And these components are differentiated into peripheral and central axis by the osmolarity. The osmolarity of peripherally induced TPN should be between 600 to 900 milliosmolar, wherein central axis it can be beyond 1000. And most of these components are available in the standard bags: sodium, potassium, calcium, and magnesium. And this is easy method to calculate the osmolarity of the PN formulation. Dextrose 5 per gram. So 5 milliosmolar per gram. So into 170 gram, I've just taken an example of 1 liter. So 850 milliosmolar, 10 grams of per amino acid. So 60 grams. So 600. And fat emulsion, it is 0.71, so 20. So all put together, it comes up to 1,700. This is how you look at the osmolarity. So whether you give it continuously or bicyclic. Mostly in hospitals, we give a continuous administration for 24 hours, which is very well tolerated. And the only drawback is that patients' mobility is restricted. But when we talk about long-term PN or home TPN, it is cyclic method that we follow. Intermittent breaks can be given, and in the long run, it can be only nocturnal PN which can be given. Morning, the patient is left free to have his normal routine at home. So general principles, hypertonic TPN only through central venous line, and line to be inserted by experienced operators. Dedicated port is very, very important. It should not be used for medication blood preparations. So a separate port for total parenteral nutrition is mandated. It has to be earmarked. Solution should be administered slowly over 12 to 24 hours. TPN bags should be changed or reduce infection. Once prepared, no other solution can be infused inside. And IV tube should be changed for the bags every day. And importance of monitoring, weight monitoring is important, baseline blood work, so that we correct the sugars or the nutrients like magnesium, phosphorus, potassium. All these has to be corrected if in case the patient is severely malnourished. And clinical review perspective, look at the vital signs, fluid balance, catheter care, sepsis review, blood sugars on a daily basis along with body weight. So full blood count weekly, it has to be monitored, and renal daily till they are stable. Later, it can be twice a week. Calcium, magnesium, phosphorus daily until stable, then twice a week. Liver function test weekly. Lipid panel 1 to 2 times a week. And this is an elaborate, monitoring chart which can be followed. Make sure you do not increase the daily target beyond 110 or go below 80% of the prescription. The ideal is between 80 to 110. So the different parameters what you look at are put here, which is very, very important. Why we talk about weight is because there can be fluid accumulation or drastic fluid loss, which has to be corrected. Okay. And don't forget refeeding syndrome, especially why do we monitor on a daily basis? We look at the magnesium, phosphorus, and potassium. That's because any patient who is at risk of severe malnutrition or who is starved will have glyconeogenesis or increased glyconeogenesis and protein catabolism, which can lead to depletion of protein, vitamins, minerals. And there is a switch over from catabolic state to anabolic state, leading to a change in the fluid, salt, and nutrient content. That's because the basic energy source is carbohydrate, which will influence insulin secretion that can lead to increased protein and glucogen synthesis, which will lead to increased uptake of glucose, higher utilization of thiamine, and increased uptake of potassium, magnesium, and phosphorus, which leads to hypokalemia, hypomagnesemia, hypophosphatemia, and thiamine deficiency. So thiamine has to be supplemented, and to prevent deficiency, 100 to 200 milligrams IV upon admission is very important if you suspect refeeding syndrome. And what are the complications? I may not go very much in detail. I think I'm going a little beyond time. So complications related to administration is sepsis, pneumothorax, embolism, catheter occlusion, fluid overload. And with regard to refeeding, I did speak about hypokalemia, hypomagnesemia, hypophosphatemia, and you do have to look at hyperglycemia also. It is very important because in TPN there is a lot of fluctuation, and insulin dosages have to be adjusted accordingly. and mechanical complications like thrombosis, catheter occlusion, and metabolic complications like hepatic complications, as we discussed before, glycemic and electrolyte abnormalities have to be thought in mind, apart from the infectious complications, which is pretty common if they are not following aseptic techniques while handling TPN patients. Infectious complications per se, it could be insertion site contamination, catheter contamination, which is probably due to improper insertion technique, use of catheter for non-feeding purposes. That is why I said a single port has to be earmarked for TPN purpose, and contaminated tubings. So everyday tubing has to be changed. And secondary contamination is septicemia, which is also common in patients if they are not handled properly. What are the defense against PN complications? Select appropriate patients to receive PN. Aseptic techniques for insertion and site care of IV catheters. Do not overfeed, because maintaining glucose is very important between 150 to 170. Limit lipids to 1 gram per kg and monitor triglycerides. If you're going to overdo on lipids, you might have a major change in their triglycerides in the long run, that too especially long-term TPN. Adjust protein based on metabolic demands, monitor fluid, electrolytes, mineral status, and provide standard vitamin and trace element preparations daily. Recommendations for storage: it has to be stored in a dry place. It can be prepared and given for 24 hours, and these bags have to be stored in dry, cool place. Temperature is very, very important. Temperature control in storages, because once it is mixed, the risk of microbial contamination and physiochemical changes are expected to increase if in case you are increasing the timeline beyond 24 hours. And can we add medications to PN solution? This is a common question people ask. Can we add insulin? There are hospitals who do practice, but why shouldn't you add insulin? Is because when regular insulin is added to PN solution, 35% of the insulin may adsorb to the bag within 24 hours. And albumin is not recommended to be added into the bag because it can cause instability, and H2 antagonist can be added is what they advise. But in our practice, we do not add anything to the bag. Heparin should not be added. That is because creamy white precipitation happens, which can cause instability. And when we talk about transition feeding from parenteral to enteral, introduce EN feeding at a lower rate of 30 to 40 mils, establish tolerance, and decrease PN slowly to keep the nutrient level at the same prescribed amount. Discontinue PN if 50 to 75% of the targets through EN is met. When we talk about EN to oral, ideally accomplish by monitoring oral intake and concomitant decrease in nutrition support until 75% is met. And oral supplements are encouraged once oral feeding is initiated. And to conclude, multidisciplinary approach is very, very important when we talk about total parenteral nutrition. The physician takes the lead in ordering the clinical, initiation of TPN. Dietitians recommend the type of TPN to be prescribed, to be given, and verifies the TPN prescribed. And pharmacy people usually dispense the TPN order. And here we do not, prepare TPN in our hospitals, but globally, if you see, the pharmacists play a major role in preparing TPN under aseptic conditions, and nursing administers or monitors the patient response. So nutritional care depends on a teamwork, interprofessional, multidisciplinary team. And that is what we are together. Doctors, nurses, and dietitians today, we have come together in this webinar to form this collated work as such. And I'm proud to say that I am part of a nutrition support team. And without a dietitian, this team is not complete. Thank you.
Thank you, ma'am, for your wonderful presentation. It had a lot of information delivered in simple way. I hope everyone enjoyed it and has benefited with listening to you.